Yeah, good morning everyone. Today I am going to discuss about vertical jaw relation. So, for every complete denture patient, after impressions we will do secondary impression and border molding. After that we will do jaw relation. Jaw relation is nothing but we are relating maxilla to the mandible. So basically in the jaw relation we will be having three types of jaw relation. One is orientation jaw relation, second is vertical jaw relation, and third is horizontal jaw relation. First is orientation jaw relation. What is orientation jaw relation? In orientation jaw relation we relate maxilla to the cranium, and in vertical relation it is the spatial relationship of maxilla to the vertical dimensionate rest to the vertical dimensionate occlusion. And what is horizontal jaw relation? In horizontal jaw relation it is also called as centric jaw relation, where we take horizontal relationship of maxilla to the mandible. Okay, so these are my contents. Introduction. So this is an occlusal rim. This is maxillary occlusal rim and this is mandibular occlusal rim. This is after completion of the jaw relation. In orientation jaw relation, what we will do? First we will relate this maxilla to the cranium, that is with the help of face bow and with the help of fox plane. Anteriorly, this orientation jaw relation we will relate anteriorly with the interpupillary and posteriorly with the ala of the nose to the tragus of the ear. Okay, that is orientation jaw relation. Second is vertical jaw relation, means this height. So what should be the height of maxilla and what should be the height of mandible according to the physiological rest position of the patient. Okay, so that is vertical jaw relation. And horizontal jaw relation is relationship of maxilla to the mandible in horizontal relation. Okay, same, this is called as jaw relation. The stage of relating upper and lower residual ridges is known as registration of jaw relation. And after recording the jaw relation, what we will do? We will transfer this jaw relation to the articulator. So these are the three types of jaw relations. Then the most important point in this vertical jaw relation is vertical dimension. So what is vertical dimension? It is basically distance between two selected anatomic points. Okay, generally there will be 2 points which are anatomically present, means it should not change with age. So that 2 points we will take and we will record the vertical dimension. So in this vertical jaw relations, what are the 2 points is tip of the nose and prominent position on the chin. Okay, one is fixed point and other is removable point, movable point. Okay, then in vertical jaw relation, 2 names you should remember. One is vertical jaw relation at rest and vertical jaw relation is one vertical jaw relation at occlusion. So vertical this is vertical dimension of occlusion, VDO, whereas vertical dimension at rest is called VDR. Okay, vertical dimension at occlusion, here same, here we will measure 2 points from tip of the nose to the chin we will measure. Okay, and these 2 points will be measured at occlusion. Okay, this is called occlusal vertical dimension, means we will record these 2 points at maximum intercuspal position. Okay, that is called vertical dimension at occlusion and vertical dimension at rest. Here this is the position where the patient's condyle will be resting in the most comfortable position and most unstrained position. Okay, this is called vertical dimension at rest. This is also called as physiological rest position. In this position, the muscles which support the mandible are in minimal tonic closure. Okay, this is most unstrained and comfortable position for the patient. So this rest position will remain same in edentulous patient as well as in dentulous patient. So for any jaw relation, 2 important factors are important, that is neuromuscular control and mandibular musculature. this is the picture with teeth with occlusal stop, and this is the teeth without teeth where we don't have occlusal stop, but still the vertical dimension is maintained with the muscles. And this physiological rest position will change with the head position. Okay, so always the physiological rest position should be recorded with the upright position. So this vertical position, as I told you earlier, this will be maintained either by occlusion of the teeth or by balance a tonic contraction, and that means opening and closing of the muscles. Here the muscles will be in balance tonic contraction. Okay. So what is the significance of vertical jaw relation? Basically, it provides optimal separation between maxilla and mandible. So this vertical dimension will ensure that there is optimal separation between maxilla and the mandible. So if you don't record this properly, here the muscles will be strained and TMJ will be strained. So what is intraocclusal distance? Intraocclusal distance is nothing but, as I told you earlier, there are two components, VDR and VDO. Here this intraocclusal distance or freeway space, it is VDR minus VDO, means vertical dimension at rest minus vertical dimension at occlusion. So it is basically 3 to 4 mm. We will record this when the mandible is at physiological rest position. It is also called as intraocclusal distance. This is also called as freeway space. This is named after a scientist called Silverman. It is also called as Silverman's closest speaking space or freeway space. Okay. See, as I told you earlier, this is vertical dimension at rest. This is vertical dimension at occlusion. Can you see there is the separation between teeth? Here it is maintained by rest position of the mandible. I'll tell you in detail how to record VDO and VDR. As of now, you remember this. This is vertical dimension at rest and this is vertical dimension at occlusion. So freeway space is vertical dimension at rest minus vertical dimension at occlusion. Okay. So if you get 52 centimeters of vertical dimension at rest and you got vertical dimension at occlusion as 49, so if you minus that value, you will be getting 3. So it is in between 2 to 4 mm. Ideally the freeway space should be 2 to 4 mm. So how to do this procedure? Okay. First we will make cast from the final impression. After that we will we will prepare the occlusal rims. These are occlusal rims. Okay, this is maxillary occlusal rim, this is mandibular occlusal rim. In the maxillary occlusal rim, the dimension should be anterior 4 mm, in the premolar 5 mm and in the molar region 6 mm. For mandibular occlusal rims, in the anterior 4 mm, in the premolar region 5 mm and the molar region it is 6 mm. Okay, and the height should be 22 mm in the anterior region for maxilla and 18 mm in the posterior, whereas for mandible overall we will make it as 18 mm. These are before we will make these measurements, and after that we will modify these measurements in the patient. Okay, and this is something called as Alma gauge, where you can measure the teeth from the incisive papilla. Generally, the maxillary incisors should be 8 to 12 mm from the incisive papilla. So, what are the instruments you require for this procedure? Okay, first thing is there should be prepared set of occlusal rims, modeling wax, wax knife, metallic trimming instrument, Wills gauge, denture adhesive and staple pins. So first when the patient enters to the lab, we will ask enters to the clinic, we will ask the patient to sit erect with head unsupported. Then we will attach 2 pieces of adhesive papers. We will make them as triangular shape and we will attach, as I told you earlier, there are 2 points. One is tip of the nose and other is chin. We will ask the patient to attach this, we will attach this adhesive tapes to tip of the nose and the chin. And we will ask the patient to relax. So So after that, the mandibular occlusal rim height is adjusted. It is adjusted such that when placed in the anterior region, it should be just below the level of dry wet junction of the lip. Okay. So posteriorly, the occlusal rim is adjusted to the angle of the mouth to the midpoint of retromolar pad. The maxillary occlusal rim adjusted based on soft tissue support. So how much support the occlusal rim is giving to the lip. If it is less, we will add more wax. If it is more, we will reduce the wax. And contour of the upper lip and nasolabial angle. And another important thing is visibility. So when the patient smiles with the rim, there should be 1 to 2 mm of visibility of the rim. If it is more, we will reduce. If it is less, we will increase the height. Okay. As I told you earlier, anteriorly the occlusal rim is adjusted according to the interpupillary line and posteriorly to alatragal line. Okay, after establishing orientation jaw relation, we will ask the patient to repeatedly pronounce M, so that the patient mandible will come to relaxed position. In that position, we will record vertical dimension at rest. Okay, we will ask the patient repeatedly present M or Om like that. Okay. And after that, we will ask the patient to, when we say patient to pronounce M, there will be slight separation between maxillary and mandibular arches, that is freeway space. So that you will record. After that, you will ask the patient to clench, so that maxillary and mandibular occlusal rims comes into contact. Okay, at that position you will record vertical dimension at rest. And you can also cross verify this with asking the patient to say S word. When patient pronounces S word, there should be 1 mm of space present between both the occlusal rims. Okay, after that you will record the centric jaw relation. Then after that you will mark the midline and close that rims with staple pins. So what happens when VD is altered? Means you are giving more height of the occlusal rim so that vertical dimension will be more. If you give like that, what happens is there will be increase in chin nose distance, and patient will be appearance from the chin nose distance will be more, and open mouth appearance will be there, and there will be improper phonetics. Your phonetics will be affected and soreness of the tissues, and there will be more bone resorption. What happens if you decrease the VD? Means if you reduce the occlusal rim height more and VD is decreased, then it will damage the TMJ, then tongue space will be limited, and there will be over closure of the face, so there will be facial distortion, and the commissures of the lips turns down and the lip lose their fullness. And muscles also will lose their tonicity, so eventually you will get angular cheilitis. Methods of determining vertical dimension of rest. Okay, here these are the methods for recording vertical dimension at rest. There are other methods which will record vertical dimension at occlusion. So basically these are 5 methods. First is facial measurements, second is tactile sense, third is measurement of anatomical landmarks, 4 is speech, and 5 is facial expression. So first thing, this is facial measurement. As you can see in this picture, we are measuring the patient based on 2 anatomical landmarks. Okay, we will place 2 points as reference. We will ask the patient to sit upright and relax, and here we will instruct the patient to wipe the lip with tongue and swallow and drop his shoulders. Okay, means with that we will be achieving rest position. We will measure this, repeat, and we will take an average. Next is tactile sense. Tactile sense is nothing but in this procedure we will ask the patient to stand erect and open the jaws until strain is felt. We will ask the patient to open the jaws till that strain is felt, and we'll ask the patient to close slowly so that a comfortable position will be achieved, that is relaxed position. Okay, next is this is measurement of anatomical landmarks. Here what they'll do is with Will's guide, here they'll measure the distance from forehead line to this pupil, and from pupil to base of the nose, and base of the nose to chin. Here they say that the face is divided into equal thirds, so they'll measure the upper 2/3 and they'll take that value as a guide to make lower third, means this distance. Okay, and speech. So here in the speech method, as I told you earlier, we will ask the patient to repeatedly pronounce the M letter. The distance is measured once the patient stops. And facial expression, while after placing the occlusal rims, you will observe the facial expression of the patient. Means you will observe the skin around eyes and chin, and it should be in relaxed position. Okay. Here upper and lower lips have slight contact in one plane. So these are the 5 methods to record vertical dimensionate rest, and these methods are to record vertical dimensionate occlusion. They are mechanical methods, pre-extraction methods and physiological methods. I will be discussing them in detail. Okay. The first thing is mechanical methods. The first thing is ridge relationship. Here what they will do is they will measure the distance from incisive papilla to the maxillary incisor and incisive papilla to the mandibular incisor. Here you can see this is the mandibular teeth, this is the incisive papilla. From here to the mandible maxillary teeth they will measure one distance, and the distance is 6 mm. From incisive papilla to mandibular incisors the distance is 4 mm. So when this is maxillary teeth and this is mandibular teeth, when they occlude, this overlap should be 2 mm. Okay, that is ridge relationship. Next is parallelism of ridges. This is given by Sears. Here Sears said that the mandible is parallel to the maxilla only at occlusion. Okay, so indicated that correct video can be obtained only when maxillary and mandibular arches are in parallel relationship. Okay. Pre-extraction record. So if patient comes to you before extraction of all the teeth, you can make certain pre-extraction record, such as taking impressions and articulating that cast, so that you will know the video, and taking x-rays like lateral septs and OPGs. Okay, and you will compare this with those made with occlusal rim. So what are the disadvantages of this technique is it is time consuming, and you may have distortion of the x-rays, and unnecessary we are exposing the patient to the x-rays. Profile photographs means we will ask the patient to get his previous photographs. So how will you measure vertical dimension with that photographs? We will enlarge the photo to the life size, means to the original facial measurements. Okay, previous photo when the patient is having teeth, and we will record the measurements on the photo. The same measurements we will try to copy in the patient. So profile silhouettes, all of you know cardboards, no? What we will do is when the patient had teeth, okay, we will cut the cardboard according to the face. Okay, when the patient had teeth. Same when the patient becomes edentulous, we will use that profile silhouette and we will re-establish that vertical dimension. Articulated cast, as I told you earlier, you can see in this picture. Here we are taking impressions when teeth are present, and this is without teeth. We can measure this vertical dimension. Okay, Next is facial measurements. Means with the help of Will's gauge, we will measure the face before extraction of the teeth, and we will take that as guide after extraction to re-establish the vertical dimension. So format dentures. If the patient is already a denture user and he wants new set of denture, we will take the vertical dimension of the previous denture and we will try to copy the same in the new denture. Physiological method. Physiological method, this is given by Niswanger. As I told you, there will be points upper lip below the nasal septum and on the chin. We'll ask the patient to swallow and relax. And the distance between 2 points is marked. The occlusal rims are adjusted until 2 to 4 mm of freeway space is obtained. Same which I told you earlier, it is the same method. This is given by Niswanger. Phonetics and aesthetics. So we will ask the patient to pronounce some sounds to evaluate whether our vertical jaw relation is correct or wrong. For suppose we will ask the patient to pronounce word S. When patient pronounces S, there should be some space existing between upper and the lower teeth. Okay. If both the teeth are touching when patient says S, then you should correct your vertical dimension. Okay, when patient pronounces words such as F and B, when patient pronounces F, the upper teeth should touch drivet junction of the lower lip. Okay, when the same as with the word V. Silverman's closest speaking space, there should be 2 mm of space when the patient pronounces S word. Okay, aesthetics. As you can see, vertical dimension. In vertical dimension, the lips are, when the patient is in relaxed position, lips are even anterior posteriorly and it should be in slight contact. If the face appears strained, then your vertical dimension is more. You have to reduce that. If face appears too close, then your vertical dimension is less. You need to increase that vertical dimension. Swallowing threshold. Here what they say is when the patient swallows, the teeth comes into contact. So edentulous patients, is they have no teeth, we will record while recording vertical dimension, we will ask the patient to swallow. There is one method where they have placed maxillary occlusal rim and lower they have placed this wax and they have simulated saliva and asked the patient to close. Okay, here these are okay, wait, these are cones of soft wax. Okay, this is little hard than this, so with more height they have placed these cones of soft wax and will ask the patient to swallow. So while swallowing, these cones will be reduced and comes to the correct vertical dimension. Tactile sense. So here there will be central bearing plate on the maxillary occlusal rim and central bearing screw on the mandibular occlusal rim. We'll adjust the screw till correct vertical dimension. This is Boo's biometer. Here there will be a pressure gauge. So with that pressure gauge we can measure the maximum pressure that is exerted while the patient closes the jaws. So where we will get the maximum power point, there it will indicate correct vertical dimension at occlusion. These are the latest techniques such as electromyography, which records the activity of the muscles. With the help of this new technology also we can we will know whether the vertical dimension is correct or not. This is one study conducted by Lada et al. Here they have measured the index finger and little finger to know the vertical dimension of occlusion. Here they have measured it with interpupillary distance and vertical dimension. So here in this study, males showed more correlation when compared to females. So conclusion, the determination of an aesthetic and functional VDO should be regarded as a basic and fundamental procedure that should be considered at beginning of all the dental rehabilitations. Since there is no precise scientific method of determining the correct vertical relation, the registration depends upon the clinical experience and judgment of the profession himself. And these are my references. Thank you.